Hello and welcome to day two of Dealing with Angry Patients. And I'm with Dr. Bob Wright, and we'd like to welcome you to day two and get right to it. I guess we're starting a little bit early, so I guess we can have a little bit of a conversation about reviewing what we did yesterday before we actually get started. So I'll turn it over to Dr. Bob. We'll go from there.
Yeah, I'm just having fun here with my computer this morning, making sure, actually this afternoon, making sure that if you see me looking around, it's not because I'm looking around, it's because I have three different screens that I'm working on. But predominantly, we're looking at here session two, mental wellness as a continuum of what we're working on today. We'll go ahead and get started here. My good friend and colleague that we've known for a number of years now, Dr. Aubrey Daniels, wrote in his latest book on the picnic analysis, although many people think they understand how behavior works, our experiences, they do not. And of course, yesterday we talked a little bit about the fact that we've been behaving, and as a species on this planet, we've been misbehaving a lot over the last bunch of millennia since we were founded. But I find it interesting that after all these many millennia, that we still have the experience of saying our people really don't understand how behavior works. So we're going to get into some of that today because we don't deal with a normal day-to-day patient, or person. We deal with people who come into the hospital. And so yesterday I gave you a little bit of an introduction on applied behavior analysis and why we use that. And so today I'd also, just for some people that may be joining us that didn't get yesterday's session, a quick review of what we talked about, certainly not as long as the discussion yesterday. And again, I remind you that most of the people who are violent are not mentally ill, and most of the people who are mentally ill are not violent. If you've studied anything to do with schizophrenia and schizoaffective disorders, or people who are bulimic or anorexic or obsessive compulsive, these people may have a diagnosis related to mental illness, but the fact is they're predominantly not violent people. And so most people have a tendency to look at people who have a diagnosis on the spectrum for mental illness as perhaps being dangerous, and that is simply not the case. The biggest issue that we have is down there, you see in the red letter, substance abuse is a major contributor to violence, and you have more opportunity to see people with substance abuse than you will have people to see who are on the mental health spectrum. So as we went back yesterday, we described a definition that we use as a working definition here, which is a combination of the gentleman on the right, Dr. Lee Allen Dugatkin, Dr. Aubrey Daniels in the middle, and then Emily Dickinson on the left. Emily is not a psychologist. She's not a psychiatrist. She was a poet back in the 19th century, and actually had the best definition of behavior. Behavior is what a man does. It's not what he thinks. It's not what he feels. It's not what he believes. In fact, if you take the combination of definitions of these two gentlemen and lady, our working definition is behavior is what people do. It's observable. It's measurable. And we respond to internal and external cues. External cues, or anything that's in the environment. Anything that is internal, like hunger, is an internal cue. Thirst is an internal cue. Pain is an internal cue. And it changes our behavior when any of these things occur. So going on, the other thing that changes our behavior, and I didn't get into this a lot yesterday, but I would like to at least touch on it a little bit, because we do live in a multicultural society here in the United States. If you check the records, I think you'll find that every culture in the world has a significant number of people living here in the United States. And we are that big melting pot that everybody has described, but I tend to want to refer to it as a big stew pot, because a melting pot blends the best of all characters together, and it's more like a fondue, and it loses all of its personal identity, but the whole is greater than the parts thereof. And so those little fondues of multiple cheeses are very tasty, but they don't really represent who we are as much as a stew pot does, because if you put a potato in a stew pot, you don't have potato soup. You have a potato till you put the peas in and the corn in, and then you put in the carrots, and you maybe slice up a little beef and put that in there, and you put in a little beef stock or a little vegetable stock, and all of these things, and the onions and the mushrooms and whatever you happen to throw into your stew pot, all come together to create a really good meal, but they don't give up all of the constituent parts made thereof. So we're a bit of a stew pot. And as we look at behavior, I also look at the ethnic background. Gender has an impact. Gender preferences these days has an impact. Our abilities, our disabilities, any of the social preferences that we have, and in fact our belief systems, along with another 175 or 178 different variables that all pull together to create this thing that we call people in the United States. So we break it down, and we have African Americans, and we have European Americans and South American Americans, and we have every combination you can think of. And if it were just in the beginning, God created man and woman, and we had variations there. But over the generations now, we have male, we have female. I'm seeing some other things coming out in the literature that are very curious, very interesting. If you look at the sexual preferences of our population, we have people who are bisexual, heterosexual, homosexual, all of these different combinations, and each of them has an impact on the behavior of the individuals that we deal with. So they bring all of that when they come to us in a healthcare facility as a patient. About the only thing they all have in common is they behave, or in many instances they misbehave, and that's part of why we're here today, is to get in some of those misbehaviors and how we manage that between today's session and the session that we have coming up on Wednesday. But the important line on this page is, as nurses, if we do not understand the science of behavior, we're going to be constantly frustrated with the people and their not so common sense behaviors. We also covered yesterday in our conversation the ABCs, not airway, breathing, and circulation, that most of us are familiar with, but we covered the ABCs, antecedents, behaviors, and consequences. And the antecedents, as we described yesterday, is anything that comes before a behavior that may, in fact, cue that behavior or lead something to follow it. There's no guarantee that the antecedent will cause a behavior, but it's highly likely that it could. And then this behavior occurs, whatever it happens to be. And generally following a behavior, there is a consequence, and that is what happens to us after that behavior. And the things that we all share in common is the consequence will either increase or decrease or maintain the behavior that we did just before it. And what we also have learned in the past is the most powerful form of getting people to do things is through positive reinforcement. Now, Dr. Daniels, in that consequence management side of things, looked at least 3 areas that he said these things will make a behavior or break a behavior. And he said the first deals with outcomes. Is that consequence good for us or bad for us, or as he called it, positive or negative? Is that consequence immediate or future in a parameter he calls timing? In that if it's immediate, the consequence occurs while that behavior is going on, and sometime in the future is any time after that, from generally more than a few minutes to days. And then the third thing that he looks at, is it likely, or rather, is it certain or uncertain that the consequence will happen? We modified that, as I mentioned yesterday, we modified that from certain and uncertain to likely and unlikely, simply because in medicine, there's very little that is certain, and there's very little that is uncertain. It is what it is. We can't go forward to a person, even though we have years of experience with antibiotics, and say with a high degree of certainty that if you take these pills for 7 to 10 days or whatever the prescription is, it will certainly cure you. I think that takes a legal risk that we should not be taking. It's highly likely that you're going to get better. We're going to measure it and monitor it, make sure you are getting better, but it's going to be likely you get better as opposed to certain that you get better. In addition to this, as we discussed yesterday, we added a 4th parameter that Dr. Daniels back in 1985 did not add, and that parameter deals with perception. Is our patient aware of the consequence of the things that we're having them do? If they're taking their medication, is it this covert action that quietly occurs at the cellular level that we just never really notice? Or is it something like a rescue inhaler where you take it, you have a little respiratory distress, you use your inhaler, and instantly it clears it up, and you're aware that it happened? So things that are positive, immediate, likely to occur that we're aware of is very similar to Dr. Daniels' pick. It is positively reinforcing. We're going to do it as often as it is positively reinforcing. So that's some of the stuff that we reviewed yesterday. And then I also gave you this circular wheel, because behavior kind of, once it gets rolling, it rolls. And so we have our antecedents followed by our behaviors, followed by our consequences. The consequences, if they're positive and immediate and certain, in the case of, say, nurse performance, is probably going to lead to another antecedent, or the consequence itself becomes the antecedent, and we will continue the behavior, we'll get reinforced, we'll continue the behavior, we'll get reinforced, and we'll continue that behavior until we are either satiated or it's no longer reinforcing to us. One thing I did not talk about yesterday, and although I think I mentioned it briefly, is applied behavior deals with what people say or what people do. And this wheel that I have up right now deals with the thoughts and the feelings and the beliefs that people have. So this is what's referred to as a feelings wheel. So if someone says I'm mad, well, mad's not a behavior. Now, yelling at you because I'm angry, yelling is a behavior. Using obscenities is a behavior that we would describe as being mad. If we move to the left of that and we say, well, my patient seems to be sad, I don't know what's going on. And the reason we don't know what's going on with these feelings is because they're internal events. Something's going on in the thoughts and the feelings and the beliefs of this patient or a cohort, a coworker or what have you. And you can't see that unless they use a verbal behavior and say, I'm really feeling sad today. For example, I had to put my dog down yesterday. And so you are depressed, which is another feeling. And you can demonstrate that. You may be crying, which is a behavior that we can measure. Everybody can look at the person whose pet was recently put down. And if they have tears in their eyes and they have a very sad face, we can say that person is sad. Not because of what's going on internal, those private internal events, but because of what we see coming on the outside. This is important when it gets into escalation and de-escalation of patient behavior, because we may not be able to see the things that, as the patients, they came into the dining room and they sit down, all these sudden events may have occurred, and a small antecedent behavior of somebody bumping in their wheelchair causes them to explode. And all we see is this angry or this mad feeling come out in the way of yelling or throwing things or doing any of these behaviors that we can measure, that we can agree, yes, he just threw the plate, or yes, he just yelled at this individual over here. But the internal events, again, we cannot see. So as nurses working in de-escalating patients, we can perhaps state, and it's always risky to say, I can understand how you feel, because you'll find out very quickly that a patient can turn that around and say, unless you've had this and this and this happen to you, there's no way you can understand how I'm feeling. But you can certainly appreciate how they feel, and you can inquire with them a little bit more about what's going on the inside, and we'll get into some of those details a little bit more tomorrow. So that is a feelings wheel that I found in the literature out there that I thought I would share with you, because we do go thoughts, feelings, and beliefs. Now we have, and I think without touching my computer, I'm seeing things move ahead very quickly. Now I'll move back very quickly. So this platform is very, very sensitive. So one of the things I don't think we take a look at with our patients is, what was their life like before they came into the facility? Who are they? Were they an executive? Were they like this one patient that I had several years ago, who was a street person, and she was actually hit by a car, and she came into our facility following her acute evaluation. She had multiple abrasions, no broken bones, and was extremely angry when she came through the doors and was put into a room. And I walked into the room to see how she was doing, and she immediately yelled at me and told me to get the F out of her room and don't ever come back. And I thought, well, that's kind of awkward. I need to pursue this a little bit more. But I did leave her room because she became quite upset. And when I say upset, upset is one of those words that really doesn't say a whole lot, but I would say that she was yelling, she was using obscenities, she was making hand gestures, and a variety of behaviors that anybody else in the room could see. So I left the room. To do a little bit more research on her, I found out that, again, she lived on the street. She was a street person, and she made her living through prostitution, and she was on drugs. And the reason she was admitted to the hospital in the first place was she stepped out in front of a car who managed to throw her down. So they admitted her to the emergency room. She was in the acute care facility for a couple of days, and then the acute care facility sent her over to us for some rehab before we sent her, if you will, home. The only men that she ever dealt with in her life were either giving her drugs or selling her drugs, taking advantage of her sexually, or she was selling her body to them. And so men were not looked at as being someone that she could be friendly with. She, in fact, hated, as well demonstrated by her behaviors, anybody who was not a John trying to give her enough money for her drugs. So it was kind of an awkward event there. But for many of our patients, they fall into those two categories you see up there. They're employees, they work somewhere, and they do that for about 2,080 hours a year, or they're at home and hopefully engaging with their family in another 6,600, and there's 8,760 hours for all of us that we get to share individually and in our families and with others, but not one of us gets an extra hour beyond that. As you know, I'm a professor in nursing, and most of my nursing students have the employee position, they have the family position, and then they have the full-time nursing student position. And about the only thing that they can sacrifice is those 2,920 hours of sleep. Other than that, they're putting another 2,000 hours in studying or sitting in a classroom. So they're pretty exhausted all the time. But back to our patients, they're dealing with one of two areas. They're either working somewhere or they're in their off time with their families. And depending on what's going on, if you are working for your boss, you've got policies and procedures that guide your day-to-day operations. You have skills that you've learned either on the job or you have learned them in a trade school or in college, and you apply those. And the consequence is you get some job satisfaction, you get maybe some occasional praise from your boss. The more important thing, you get paid for your time, and then you can take that money home and spend it on the kids and the wife and the mortgage and the utilities and the other things that you have there. It can afford you the opportunity to do those 3,760 hours of doing whatever you want to do um, beyond just sleeping. So the reason I put those up there is that when you are admitted to a hospital, the world changes radically. Your patient's world compresses down, and they've come away from the areas that they know the best, their home and their employment, and now they're in our world. And we as nurses and clinicians use an entirely different language. If you go to Dr. Atul Gawande, is a surgeon and writer, writes for the New Yorker magazine, brilliant physician, brilliant writer, somebody I would recommend all of you to pick up and read some of his things. But Dr. Gawande, in about 2010, was addressing the Stanford University graduating class, nurses and physicians and psychologists and so forth. And he was talking about the things that we learn as we go into the fields of medicine and nursing that we go into. And we learn about 13, 14,000 new diseases, and we learn about 6,000 medications, and we learn about 4,500 procedures. And all of these processes that we put into our brain have their own language. And so we actually walk into our patients and we do things like, well, we're going to have you ambulate down the hallway. And that's one of the things I teach my nurses is we're going to spend a lot of time teaching you a new language. And then I want you, when you're with a patient, to forget most of it. Okay? Don't go ambulating with your patient because it adds to their confusion. How about we're going to go for a walk and I'm going to assist you on that walk? But the patients are now managing a lot of things going on. They're not at home. They're not in charge. We've taken away their clothing. We've taken away literally their identity. We're essentially saying, we don't trust you to tell us who you are. So we're going to put a band on you, and we're going to put another one that says what your allergies are and any other special bands that we can come up with. And every time we walk in your room, we're going to say, can you tell me who you are? And we're going to take your hand and we're going to look on your wrist. And then we're going to agree. And then we're going to ask you for your birthday. So, and then we're going to tell you this is the time you can get up and this is the time you can go to bed. And this is the time you're going to have your physical therapy. And this is the time you're going down for this procedure. And oh, by the way, you're due for a chest x-ray in the morning. So we're going to wake you up at 4 o'clock in the morning. We're going to put a cold plate behind your back. And then we're going to have you lean back, and then we're going to have you take a deep breath, and we're going to take the picture, and then we're going to come out, and you're just about to go back to sleep when the lab comes in, and they're going to stick a needle in you. So we've got this constant, ongoing set of things that really interrupts your sleep, interrupts your thought processes, interrupts the way that you've had your life. And on top of that, you're sick. On top of that, you're worried about, okay, do I have enough money coming in? Do I have enough sick days that I'm going to be able to pay the bills for that other side of the equation that we have over there of being home? What's going to happen to my job? Who's doing my work while I'm gone? So our patients have a lot of thoughts and feelings and beliefs and anxieties along with just the life-changing events that are going on that could be shocking to them. Most of us don't have significant problems for most of our lives until we hit an age certain, and then boom, might have a little chest pain. Well, we got to rule out the MI. You might have a little pain in your right upper quadrant, and you're a female, and you're a little overweight, and you're fair-skinned, and you're 40 years old, and now we're thinking of gallbladder. So all of those things take us away from normostasis, if you will, into an environment where perhaps my life is at risk. Certainly my freedom is at risk. And maybe I won't be able to get home in time for some kind of event. And all of these things stack up on our patients. And then you walk into the patient's room. And what happens there? Well, what we're really doing here is dealing with the patient's mental health. And as I tell my students, I teach the psychiatry and mental health nursing component, as well as I do a lot of the med-surg clinical side of things. And as I tell my students on the very first day of psychiatry, is that every one of you is a mental health nurse. And this is the only course that you're going to take that will affect everything you do in the field of nursing. And so you really need to pay attention. You may not be working with schizophrenics. You may not be working with people who have any of the other DSM diagnoses that are out there. But the reality is you're dealing with someone on the spectrum who now may be depressed. So what is mental health? Mental health, as we say here, is a state of well-being. The patient realizes that their abilities to cope with everyday stresses on that big circle over to the left-hand side of the page, that they're very comfortable, they can work on the right-hand side of that page, they can be fruitful, they can contribute to their community. Now they've come into us, and all of those areas have been threatened. And if you look at patient behavior, and even if you look at our staff and our colleagues' behavior, or even if you look at your own behavior, it really falls into a 2x2 matrix that I can just change a few words here, particularly within those squares, and I can address every issue that you might have as a nurse, and I can address every issue that we might, or at least identify, and I can establish what we need to do to improve that individual's can't to can. So let's look at the first two quadrants over here on the left-hand side. And many of our patients will come in and they say, well, I can't do something. Some of our nurses and some of our CNAs will come in and they'll say, well, I can't do something. And then it's our responsibility, if we're in a leadership role or we're in a nursing clinician role, it's our responsibility to understand from that patient's perspective or that employee's perspective why they can't do it. They may be handicapped. They may not have family support, so we're looking at a discharge plan. We're saying, well, we're going to send you home. And they say, I can't do that. I don't have anybody at home. So then we have to start looking up into that second tier of what supports do we have in the community? What sort of skills do we need to train this individual in? Are there any assistive devices that we need to be working with this person? Do I need to get physical therapy? Do I need to speak with a physician and say, listen, doctor, as a part of my SBAR, this is my situation and this is an observation that I have made and the patient has said this. We need to talk about their care plan and where we're going to go with it. So the can'ts generally deal with resources. It deals with not only resources, but skills and training and things that we can put our hands on to improve that patient's outlook on life. And then we move over to the other side over there, and that's the will or won't side of the equation. And the won't side of the equation is the one I think that is most complex, because in many instances, we can get our patients or we can get our employees to move from the can't side of things by managing the resources and move those up to the can side of things. But the next step is to get them to move over from the can side to the will side. And the can side, again, is dealing with what we used to say in the Army are beans and bullets and the supplies of getting things going. But on that right side, the won't to will deals with attention seeking. It deals with avoidance. It deals with thoughts and feelings and beliefs. It deals with all of those private events that are within our patient that we have to tease out. And sometimes those come out to us in the way of an individual yelling at us or throwing things at us or stating obscenities or doing many of the behaviors that we may feel motivated to call security or call the police department or call somebody in order to manage that behavior. We're going to get more into that tomorrow. But for today, our task is how do we get our patients from can't to will or can't to can and can to will, and then how do we reinforce that behavior? Okay, so now we have these physical illnesses. We have mental illnesses, we have physical illnesses, and the physical illness is what brought this individual to us. It's often used as a contrast to mental disorders. Medical disorders have available mechanical tests. Those are things that we can do, that the physicians can order, that can come in, like brain scans and the various lab studies that we do that will let us know where the patient is relative to homeostasis. Then we have the mental disorders. Then there's no lab studies that we can do. Most of the things that we do in the world of human behavior and the way that they react to their environment is by observation of the things that they say or do that we can learn from. And we need to not just discard those. And sometimes when our patients get really distressed with us and they yell and scream at us, keep in mind, you're the messenger. You don't want them to kill the messenger, but as the messenger, you're listening to what that patient says, and you're going to be carrying that message back to his or her physician or nurse practitioner or physician's assistant, whoever you think is appropriate as the nurse in charge of that patient to get them the next level of care that they need. Well, I was looking at a thing called Law Insider. It's a website, and I have their website URL listed at the bottom down there on that little floor area. And the reason I was looking at that was I was looking at the definition of mental illness, and only in the world of lawyers and the legal people can you find 220, actually it's more than 220 definitions of what mental illness is. And so I picked just the top two in terms of times used as a reference in a court of law. And so the first one had 149 citations, which this definition was used. And mental illness means a mental disease to such extent that a person so afflicted requires care and treatment for his own welfare or the welfare of others or of the community. And then the second one is a variation on a common theme, and it says a substantial disorder of thought or mood that significantly impairs the judgment, the behavior, capacity to recognize reality, or the ability to cope with the ordinary demands of life. And I'm glad that they put the word behavior in there, because other than verbal behavior or physical behavior, we would have almost no idea that somebody was mentally ill. How do we know they're mentally ill? Generally by what they say, what they do, what we observe, and what we can document. And without that, we have no idea whether this individual is mentally ill, mentally healthy, or physically ill. Well, I brought up the nurse's life a little while ago as well, because our nurses are all antecedents to what goes on that nursing unit. And I do have a number of LPN students who are in my RN program, and their life is a little bit more complex because our nurses are doing pretty much the same thing that you're doing. They're working those 2,080 hours. They're going home for those 6,680 hours. Hopefully you're getting 2,920, but I do realize, that is hours of sleep, but I do realize that we're short staffed. And a lot of you are doing doubles and you're tired and you get home and you come back to work and you find that that hectic lifestyle is a setting event for how you may respond to or act around these our patients when you come into the hospital. In the background may be a little bit difficult for you to see. There's a lot of activity going on there that we would call our setting events. And the setting events not only deals with the reality of what's going on in the world today, but it's also dealing with what's going on in your pocketbook. Uh, it seems anymore these days that we're working harder and our dollars aren't stretching as far, and that puts stress on you. And so now you're working extra hours to make up that difference. You're going into the hospital, and are you becoming a part of, you're bringing your setting events, and are you bringing those thoughts and feelings and beliefs and reality into the facility? And are you serving as a real antecedent, or are you able to manage your behavior so that you're not part of the problem and that you can back away? And we'll get into that a little bit more as well. But your life as a nurse is something that we have to consider. Your life as a parent, your life as a spouse, your life as just another living human being out in the world is something that each of us need to look at as we go into this hospital environment, to use all of our resources, all of our thoughts, all of our feelings, all of our beliefs, all of our talents, and all of our skills to then meet the needs of our patients. And when I say meet the needs of our patients, hopefully, you'll end up with certainly no more than 6 patients. And I've got those patients represented by that little ABC behavior wheel down there, because each one of those patients brings their own thoughts, feelings, beliefs, and pathologies into your realm. And how are you going to react with them? If you're working a 12-hour shift, and a lot of our nurses are working 12-hour shifts now, your patient might be able to do the simple math and say, oh, well, my nurse comes in at 7 and leaves at 7. I want my 2 hours. Well, as you and I know, there's a whole lot that goes on when we're not with that patient. And some patients take more than 2 hours, and some patients will take fewer hours. But there may be the thought and the expectation that you're there to serve the needs of those patients on a 2-hour per patient shift. And I have found that not to be the case, even if I have been a patient in the hospital. But our patients don't understand when we tell them that we'll be back. And one of the things I recommend to my students is be specific with your patients. Tell them, I'll be back in 15 minutes. And then do everything that you can. I understand, I've been doing this job of nursing for a number of years now. There are things that come up. You may have a code that occurs, and that's going to pull you out of the patient's room beyond that 15 minutes. But to the extent possible, build a reputation for getting back and responding to your patients. You'll have fewer call lights, and call lights become antecedents to your behavior of frustration. And then the consequence of that ABC analysis is that you go back into the patient's room, and maybe, just maybe, you're not quite the great nurse that you really were before you were on your last nerve. Okay, mental health is a continuum. It's not just, well, some days I'm crazy, some days I'm not crazy, some days I'm perfectly normal, other days I'm not perfectly normal. We all have mental health issues from time to time. And the literature may say that the diagnosed mentally ill represents about 20% of the population, and that the rest of us are sane, that other 80%, we are perfectly normal. But then again, it depends on what the meaning of the word normal is and what the word continuum is, because there are times that each of us have our own stressors, or we have our depressions, and hopefully they're not diagnosed or diagnosable because maybe you lose a pet, you lose a friend, you lose a spouse, you lose a parent. And yes, it's perfectly normal to be depressed when those things occur. But the question that I would ask you, and just it is a rhetorical question, is what was your first thought? As I said, mental health is a continuum. Were you thinking about your patients, or were you thinking about yourself, or were you actually thinking about, well, everybody in that environment? I had one nursing student a couple of semesters ago who was in her early 30s, and she had 7 children of her own, plus she married for a second time and picked up 2 more kids. And so every day she was preparing her day for 9 children, one spouse. She was working as a certified nursing assistant coming through the RN program and working full time as an RN student. And I was amazed with her continuum of normal mental health. I don't know what she was doing or using, but she was sane the whole time, and she did pass her NCLEX, and she's now an RN out there. But she was able to manage her continuum in a way that I just stood and admired at any given time. Um, so let me ask the second question here. When you were thinking about this continuum of mental health, did you focus more on mental illness or the fact that most of us have mental wellness most of the time? And what is the difference between mental illness and mental wellness? And what is the difference between physical wellness and physical illness? And typically, we only think of those who are diagnosed as being mentally ill, as opposed to how about your partner in crime there, that other nurse that's working on the unit with you, and he or she is having a really tough time at home. Um, to share another story, I had a young nurse who is in my RN program. She is an LPN. She's a relatively new LPN. And of course, I think we're all a bit under stress right now because of the events with Radanda Vaught. And I'm sure you're by now familiar with the Radanda Vaught story, so I won't repeat that. But I was speaking with my young nurse, and she came in yesterday and said she had worked uh, the weekend and went into work. And normally she works in an assisted living facility. Normally, when she's working, she has a cart and she has 30 patients that she is responsible for. And so she went in and she counted the narcotics on her cart and accounted for them, took a report on the 30 patients that she was going to be responsible for. And a med tech who was on a second cart came over and said, "Hey, I'm leaving my keys on your cart. Can you count my narcotics with me?" And so he could get away. She counted his narcotics, and again, it balanced. And then she suddenly realized that she had 52 patients, that there was not going to be a replacement. She called her supervisor. Well, I can tell you from past experience of my own in taking care of 40 patients that her mental health took a nosedive. However, to her great credit, she did call her supervisor, and the supervisor said, "Yes, you're it, tag. And yes, I approve of you working with 52 patients." And I can assure you that on the continuum of mental wellness, she took a bit of a nosedive, but she was able to get through the shift and was quite mentally worn out by the time she got done. Gets to the third bullet. Well, how do we demonstrate mental health to other people? And that's pretty much the way we act with each other. Again, as I mentioned yesterday, my first clinical instructor, Mrs. Lillian Burrows, talked about setting events long before the term setting events was ever really put out there for anybody to talk about. And this goes back to a long time ago. And Mrs. Burrows, even though she didn't call it setting events, it says as you're getting ready to go to work, take off your problems, take off the things that you cannot take into the hospital. Because when you walk into the hospital, you're the adult on the floor. You have to demonstrate that you are medically and mentally healthy to take care of those who are not as fortunate as you are. Too often, I think we get down there, it says in the fourth bullet, too often we look at anything dealing with mental as mental illness. But I am sure, as I watch my nursing students who are in the middle of this is week 10 in their semester, so they're taking their HESIs, there are a number of young women who are mentally healthy but terribly stressed, and I would not say they're mentally ill. There's a significant difference between their depressions, as a couple of them didn't quite get through their first HESI, so they'll have to repeat it, but their ability to cope and shake it off, it was really quite profound as I met with them today. So what is mental health? Well, it's not a binary state. It's not one in which you are mentally healthy right now and now you're mentally ill. It's like today I'm schizophrenic and tomorrow I am not. Today I am depressed, but tomorrow I will not be depressed. Today I am well, but tomorrow I am ill. It is not a binary state. It's a continuum that ranges from I'm okay, you're okay, to people who have severe symptoms. I've been following a young lady on Facebook named Lauren Kennedy. Lauren is schizophrenic with schizoaffective disorders on top of that. And she has been, over the last several years, hosting her website and vlogging, if you will, about her struggle with mental illness. And she's now married, she has a child. And she goes through this continuum. When you see her talking on the video, she's awake, alert, and aware, oriented, person, place, and time, and perfectly lucid. And she's a joy to listen to. And then she reflects back on her mental illness episodes where she said that, gee, I felt really good, so I went off my medications. And when I went off my medications, I started down this pathway, and I ended up attempting suicide. And after the attempt on my life, I was locked in a mental health unit, and I was stripped naked and put in a room, and I was secured to a bed. And again, let me also say this is in Canada. It was not here in the U.S. It's certainly worth going and looking at Lauren Kennedy and catching some of her videos if you get a chance to, as nurses out there or as physicians, because she's sharing that first person experience that absolutely points out this continuum, this movement from I am suicidal, where she has attempted suicide at least on 3 occasions, all the way up to where she is now, and a wife, a new mother. And as long as she is on her medications, and she doesn't trust that she's going to take the medication, so she's on a depot injection so that she can maintain her sense of who she is and where she is. But it's really interesting to listen to her as she describes this physical illness that she has, or this mental illness that she has. And one of her biggest concerns was when she was pregnant, can the physical aspects of pregnancy have an impact on her mental acuity as well? As nurses, I'm going to use a term here down in that second sentence from the bottom. I'm going to use the term pinpoint. And we're going to talk more about pinpoint in a little bit. In nursing, if you use the ADPI, the A stands for assess, and we'll talk about that a little bit more as well. But pinpointing really is assessing. It's getting down to what is the basic problem that I need to address, either addressing it directly with a care plan that I have, or addressing it by calling the physician and giving him or her an idea of what's going on with their patient based on my experience and observations. On this next slide, if you're not familiar with the Clinical Global Impression Scale, it basically points out that about 80% of the population is perfectly normal, whatever normal is, but at least they don't have a diagnosis that we can put down as mentally ill. They don't meet the DSM-5 definitions of mental illness. But if you look at the rest of them, from minimally ill all the way up to very severely ill, therein lies that continuum. It looks like this way, though, however, it's either you're here or you're here. And the Clinical Global Impression Scale also uses each of those as a baseline. So if, for example, I was working with a patient who was moderately ill when I went in to see them on Friday of last week, and here we are on Wednesday, and I go back in and I reevaluate them, and I'm going to say, are they worse than or better than? So if they were a 4 on Friday and they're a 3 today, that is a measurable improvement. They're now going from moderately ill to mildly ill. So we're constantly measuring on CGIS where the patient is from baseline to where they are today. Now there's more to mental illness, and I came across this chart, and I've started to use it now with my nursing students to help them understand that there is this continuum of moving in from I'm healthy in all of the little green aspect areas to I'm ill over here on the right-hand side of the page. And it addresses it in terms of changes in mood, again, mood based on thoughts, feelings, and beliefs, changes in thinking and attitude. And attitude, as I learned years ago in the military, attitude determines altitude if you're flying an airplane. And so the entire first 2 sections there on mood and thinking affect your attitude. And again, all 3 of those are private events. You cannot see them save through the behavior of the individual. down there at the third bullet, it says changes in behavior. So as a behaviorist, I like to see the B word used often because those are the things that I can measure. Now, if you look throughout this chart, you'll see that there's some words there that are in red. And I, in fact, went in and changed those because using Dr. Ogden Lindsley's definition of behavior is anything that a dead person cannot do. Okay, so or can do perfectly rather. If a dead person can lay quietly in the bed, it is not a behavior. If a dead person can lay quietly in the bed and make no orders or requests for any kind of support, they're just quietly laying in bed, it is not a behavior. Again, behavior is what a person does. So if a dead person can do it perfectly, it is not a behavior. So I went through and I looked at these and I said, okay, have intrusive thoughts. Again, I cannot see what an intrusive thought is there on thinking. I can only hear what the patient has to say in terms of their physical reacting to whatever it is going on. If I go down to physical changes, there's one down there that says some weight gain or loss. Okay. Gaining weight necessarily is not a behavior. Now, I will grant you a dead person cannot gain weight, but there's nothing involved in losing or gaining weight or seeing something like this, fluctuations in weight gain or decreases in weight, that the individual has a behavioral aspect in the fluctuation. Maybe in dieting they do. And generally you'll keep in mind this, that a behavior normally ends in an ing. Talking is a behavior, walking is a behavior, yelling is a behavior, throwing is a behavior. It's a good verb. Anything that shows an action or state of being is a verb, and you need to write that down in the nursing care plan so you can be clear as to what's going on. So this entire chart, I think I found it on the internet out there. I thought it was very, very interesting, and I put it in there. And as you get time, I'd like you to look at it and just get a feeling about the continuum between this normal, healthy person all the way over to the ill person. Another way to look at this in the mental health continuum is going, again, in a linear fashion from thriving to excelling, surviving, struggling, and in crisis. In each of these areas down here, we find that about 17% of the population is thriving, which is kind of a combination between this thriving and excelling. 57% are in this moderate behavior world, which falls all the way from thriving over here to struggling. And then we have 12% who are languishing. They're just not making headway in what's going on in the world. These are some of the more ill people that we have to deal with. And then to add the final 14%, they fall somewhere in this mentally ill and coping. They've got the problem and they're getting along with it. And so that equals 100%. So what does thriving mean? Well, it means that we're basically calm. We're performing, we're getting the sleep that we need, we're doing the normal ADLs, the activities of daily living that you and I usually take for granted. It's just getting along in life. Things are normal. I'm in a healthy state, and I'm very happy. That is thriving. Excelling is not only that, I'm enjoying life. I'm cheerful. I'm energetic. I have a lot of excitement in the things that I do and show to other people. And as we look at Maslow's hierarchy of needs, I am fully realizing my potential in the world. We move along to worried, that nervous, irritable, sad, troubled, and distracted state. We may be withdrawn. We may be anxious. We get into struggling. Again, we start with anxiousness. We go into poor performance. We're not sleeping right. We have a poor appetite. And in crisis, we're very anxious. And the people you need to pay attention to, not so much the thriving, not so much the excelling, but the people who are surviving. And on what edge are they right now? Economically, they may have been doing well, and over here may be thriving. Let me go over here to this next one. Let's back here at thriving. They may be thriving simply because the economy was good, the gasoline prices were good, the food prices, everything related to what we wanted to do to be successful was really, really good. And now we're maybe moving in another direction. And that's bi-directional because we can go from thriving up to excelling, or we can go thriving down here to surviving. And surviving is not living in the way that most of us would like to live. And surviving is better than struggling. But again, we're not up into crisis either. So thriving up here is not necessarily free from the normal cost of living, the normal things associated with living. Thriving means maybe one of your children fell and got an owie on his leg, and now you're feeling bad, but you're functioning normally in this continuum of life. Say you have a diagnosis of schizophrenia, you're doing really well. And I think Lauren If you go back and look at her, she is thriving. She and her husband and their baby are doing really, really well. They're eating well, they're sleeping well, they are having pretty much your great American life, even if they're Canadian. We move up here now to excelling, and that's a good direction to go in. I have no problems with excelling, and I would like for all of us to be excelling, but sometimes we're not all at that level. And excelling is it's again Maslow's hierarchy of needs. You are at the top of your well-being as far as the continuum is concerned. You have the right conditions going on. You're at peak functioning. Life is going well. And so if you have patients who are in the thriving and excelling, they may drop to a different level here very quickly on you. But the bottom line is be able to recognize where your patients are when they come in the hospital. If you're working with other clinicians and they're members of the hospital, they can be fairly easy to get along with. They're in their environment, they know what to expect. The noises are nothing new for them. But if you are a general business person or you're a farmer and you've been out working in the field and it's quiet and you hear the birds and all the other stuff, and when the sun goes down, you go down, and you take your little night when the sun comes up, you get up, and now I'm waking you up before the chickens get up to do all of the things I need to do. Is that possible as a setting event to get your behavior to change while you're there in the hospital with us? You'll also find excelling is a response to both internal, I feel good, and external, I'm receiving good. Everything in my life is going well. So by all the measures that I have, I'm very, very comfortable with what's going on in life. If we move up to the crisis area, that's a whole different world that we need to look at. Let me see if I can move my little thing here. Before we talk about crisis, let's go down to surviving, which is, I've described down there, it's an unsettled state of mind. People can slip into this surviving mode very quickly. They can do it from hour to hour, depending on what's going on in the hospital. So you need to be watching these patients. They're going to find it harder to concentrate on making sure they get to physical therapy. And you may be in there going, well, it's time for you to go to physical therapy. And he blows up or she blows up because they're just hanging on. And now you're throwing another variable in there. I'm going to throw in a little bit different slide here as the next slide. This is more dealing with following care plans because every one of these patients is going to be discharged. I was saying yesterday that we as nurses are consequence managers. We deal with the consequences of a patient's lifestyle, a patient's disease, a patient's response to that disease when they come into the hospital. And so we have to listen to what they say and what are the antecedents that led to the behavior that is having us manage that consequence. One of the things I also look at and have studied now for 6, 7, 8, 9, 10 years is the consequence of following care plans relative to taking medications. And this was a great study that was put out there several years ago. And of the 16 quality performance standards tied to medication adherence, what you're looking at in the upper left-hand corner in that little yellowed area is the first 30 days post-discharge. And whether or not you're tracking patient adherence, and typically as nurses in a healthcare facility, we don't do that. What we're watching is we're going to make sure we get the 5 rights. Right patient, right medication, right dose, right drug, and right route. And we're absolutely obsessive and compulsive about making sure those rights are in there. And then we're also the consequence manager in terms of teaching our patient to follow those rights when they leave the hospital. And some of the medications are going to be for a long time, and other medications may be for 7 to 10 days, depending on what it is they're being treated for. But what I want you to pay attention to is how rapidly, regardless of the disease process that's going on, how rapidly our patients stop taking their medications. And you just want to hit yourself upside the head and go, why do they do this? And it's the nature of human behavior to not do things that are not terribly positively reinforcing. And it really doesn't matter what the disease process is. If it's respiratory, the one I want to draw your attention to is this neuroscience, this antipsychotic medication here, because we start here, we drop to here, we drop all the way down here. Now we're 3 months post-discharge, and then the patient drops a little bit more by month 6. By month 7, the majority of your patients who are psychotic are off their medications, and they're going to come back in and see you. So you're going to be dealing with these patients and the impact that they're going to have on your unit. So I wanted to just throw that in there, to set a little aside before I keep going on and look at this next slide, which deals with struggling, because many of our patients are struggling. They're anxious. They're in an unhealthy state. And regrettably, many of the reasons that they are unhealthy and in that unhealthy state is because they did it to themselves. Most of this these things are unhealthy behaviors. We go back and we look at nature and nurture. And yes, nature did have some problems. I am sure that there's not a diabetic out there that worked their way into diabetes, diabetes type 1, uh, and they're having to live with the consequences of being diabetic. That is going to have a set of anxiety and unhealthy consequences of struggling with that disorder. What are my thoughts? What are my feelings? What are my beliefs? How do I act out? Particularly if you're a pediatric nurse and you're working with adolescents and they are struggling, they're not mentally ill, they're struggling behaviorally with the reality that they've got to stick themselves multiple times a day in the fingertip, and then they have to take insulin multiple times a day, and no, they may not necessarily be able to go out to McDonald's and have that Big Mac and have a biggie sized thing of fries and a biggie sized chocolate milkshake, which kind of makes me hungry right now. But nonetheless, we're going to be dealing with those children if you're a pediatric nurse, and they're going to be struggling with their lifestyle. Your CNAs are going to be dealing with these patients. They're going to be closer to them, and they may be asking the CNA, can you speak me something like this? So how does someone in this zone deal with this struggle? Well, they have a really hard time. These are not the people that, if we move into the in crisis area, these are the people who are in there arguing with you about, why do I need to do this? Why does my doctor want me to do that? And these are the people that you're going to have a tendency to say, I understand how you feel, and they're going to come right back at you and say, no, you don't. If we look at the in crisis population, now we are dealing with people who are suffering. And the suffering depends on a number of factors. Are they having physical illnesses leading to their suffering? Are they having lifestyle changes moderated by the fact that they may have end-stage renal disease, and now they're going to be on dialysis, and they're going to plan on their lifestyle causing them to be in a dialysis unit for 3 days a week for 6 to 8 hours at a time? What are their thoughts and their feelings and beliefs about that? What about the quality of life for them? Are they going to be angry with you when you walk in? These people are not surviving well when you first meet them, and they're going to be very, very angry. And you're going to be the first person that walks in the room. They're going to be angry with you. Keep in mind, you're not the target by any stretch of the imagination. So what are we going to do with all of these people in here? And the answer is, we're going to tell you that tomorrow. But I'd like to give you just a quick heads up on the person in crisis who is out of control at the thought, feeling, and belief level, and that's demonstrated at the emotional and behavioral level. These are the people that are going to be using obscenities and causing a lot of hate and contempt in the unit. They're not going to respond when you go in the room and say, I need you to do this for me. These are not the people who are thinking clearly at the time of the events that are going on at that time in their life with you. They're going to be angry. They're going to be angry at you. They're going to be angry at the environment. They're going to be angry at God. And you just happen to be standing there, and so they're going to be angry at you. They may be hyperventilating. They may be nauseated. How you deal with these people, we'll address more specifically in our next session tomorrow. Sometimes, as nurses, you'll see that we are reactive, not proactive in the way that we go about this. Case in point, a young gentleman or middle-aged gentleman who had an amputation of the right leg above the knee significantly because of his diabetes and infected foot, and we know how that works with osteomyelitis, and it slowly crept up his leg until they finally had to amputate above the knee. Reasonable individual, but if you didn't get to know him real well, it was very difficult to de-escalate him from an event that we'll share tomorrow, because he was quite angry, and inappropriately so, but our nursing staff that responded to his crisis didn't help anything by patting their feet and crossing their arms. So we'll talk about the emotional containment and how we can get that under control. In addition, we'll be talking about the out of control person. And I've had several patients over the last couple of years when I was out doing the bedside nursing part of my job that were totally out of control. And how do you de-escalate that? How do you protect your staff? How do you protect if they have a roommate? How do you engage that individual in a way to move him in a direction that is safe for you, safe for the environment? And so we'll have some very specific steps that you could take in order to both engage the patient or disengage if you need to, but to certainly de-escalate this patient from something that could be not good for you. Okay, I've got a couple of little charts here. Lifetime prevalence of violent, and the operative word is violent behavior among persons. And here's an operative word: with and or without a major psychiatric disorder. With no major disorders, you see it's about 7.3. If you go all the way over to the right side of the graph, major mental disorders, takes that number up to the prevalence of 43.6% of your patients who fall in this category. And these are people that are going to be on the psychiatric units. However, if you drop down to the next one, your substance abuse, those people, 35% of those people are going to be with you on a med-surg floor. Some of your schizophrenic patients are going to be on a med-surg floor. What we're talking pretty much over here under major mental disorders are your forensic patients who are coming out of jail with a police officer attached to them. But you're still their nurse. You're still going to have to give wisdom and guidance to everything else that's going on with this individual. You're going to have to give wisdom and guidance to the police officers or whoever is providing security for you in that environment. So in session 3, upcoming, and that's tomorrow, we're going to get more into the areas of overall goals and crisis resolution, the things that we need to enhance your being calm and reassuring and skilled as you work with these patients. And let's see if there's, I think that's about it. We're going to get into this very specifically. It also requires making post-crisis connections and lining up with this patient to keep them safe. Okay, we're also going to talk about the aftermath of crisis. How do we document that? How do we make sure that we have learned from whatever has happened? How do we share that with others? How do we share the information about the specific patient that we're working with on what the things are that we do that can escalate their behavior versus not escalate or de-escalate that behavior? And we'll talk about setting limits, how to acknowledge the person's feelings, how to be empathetic, how to speak to the individual, how to avoid arguing and being a part of that difficult patient's environment. So with that, let me ask my colleague, Chris Preisler, who's on the line, if he has something else that he needs to add. I do appreciate your time because I know that all of you are very busy clinicians out there. You have a lot of other things that you could be. If you like what we talked about today, you can let us know that. If there's other things that you would like us to talk about on behavior, staff behavior, and leadership and things of that nature, we'd be more than happy to provide other workshops. So, Chris, let me just turn it over to you, and thank you, ladies and gentlemen.
All right. Well, thank you very much, Dr. Bob. We appreciate your insights, and we just thank you for your gracious time that you've put together this 3-day event. Ask that come back tomorrow, and we will wrap up this 3-day journey. So thank you.